Okay, so get started just to get things rolling. Welcome. I've got apologies from Alex Sinclair. Joe Bushnell, I got an apology, but you're here already. And Craig and Janet, as noted, have already will need to leave by 3 o'clock. And I've got a note here that Penny Spring can only stay for 40 minutes. Um, so, welcome all, particularly welcome to our new non-executive governing body clinicians. So I'll ask you to introduce yourselves by going round one by one. And unfortunately, we've done this already in the in committee section, but because this is the first in public meeting where Joe and Alistair, who will hopefully be joining us shortly, are present, we'll need to sort of formally introduce ourselves. So I'll go around the screen in order that I've got it here. So I'm Bolesław Posmick, salaried GP in Hartlepool and in Herworth in Darlington, and clinical chair of the Clinical Commissioning Group. Jane, if you want to go first.
My name's Jane Smales. I'm the corporate support for the governing body.
Okay, Esther Mireku, you're next.
Hello, I'm Esther Miriku. I'm consultant in public health for Redcar and Cleveland and Middlesbrough councils, and I'm attending on behalf of Mark Adams, Joint Director of Public Health for South Tees.
Okay, Craig Blundred, you're next.
Hi, Craig Blundred, Director of Public Health for Hartlepool.
Okay, Karen Hawkins.
Good afternoon, I'm Karen Hawkins. I'm the Director of Commissioning for Out of Hospital Care for the CCG.
And Hassan Tahir.
I'm Hassan Tahir. I'm a GP and elected onto the governing body as a healthcare professional.
James Neverson.
Hi, I'm James Neverson, GP in Darlington and a non-executive GP on the governing.
Janet Walker.
Hi, I'm Janet Walker. I'm a GP in Eston and I'm Medical Director of the CCG.
David Gallagher. Oh, David Gallagher's on silent. No, sorry, Dave. Okay, David Gallagher's the accountable officer for the Clinical Commissioning Group. His microphone, for some reason, isn't working. Anyway, so he says hi to everybody on your behalf, Dave. Right, Jackie Keane.
Hi, I'm Jackie Keane. I'm the Head of Governance for the CCG.
Okay, Craig Blair.
Hi, I'm Craig Blair, Director of Commissioning for the CCG, and I seem to have an unstable internet connection, Pos, so apologies if I break up.
Okay, Jean Golightly.
Good afternoon, everybody. I'm Jean Golightly, Exec Director for Nursing and Quality for the CCG. Thank you.
Jessica Hollingsworth.
Yeah, hi everyone. I'm Jessica Hollingsworth. I'm a GP in Middlesbrough and I'm also one of the other non-executive GPs on the committee.
David Emerton.
Hi, I'm David Emerson, Secondary Care Doctor on the governing body of the CCG.
Joanna Bushnell.
Hi, Joe Bushnell. I'm a clinical pharmacist and I work half-time at Winfield Practice in Darlington and half-time at Tennant Street in Stockton. Just joined the Tees governing body.
Oh, welcome, Joe. Andy Mackay.
Hi everyone, I'm Andy Mackay. I'm the independent member for the CCG and I lead the Quality Committee.
Okay, Alistair Johnson.
Hi, I'm Alistair Johnston. I'm a GP in Thornaby and I'm one of the non-exec GPs in the governing body.
Mark Pickering.
Hi, I'm Mark Pickering. I'm the Chief Finance Officer for Tees Valley CCG.
And Caroline Gitcham.
Hello, I'm Caroline Gitcham. I'm the Vice Chair on the governing body as a lay member and I'm the Chair of the Primary Care Committee.
Okay, thank you very much. Welcome all. That's the introductions done. Just a quick sort of housekeeping bit. This is being recorded for purposes A, of note making, and B, also to facilitate public engagement with the Clinical Commissioning Group, and it'll be available on our website later. Ideally, if you've got mobile phones near you, if you could switch them off, use a blurry background or a CCG background or sort of an appropriate anonymous background if possible, if you can. And ideally, please to minimize background noise if you stay on mute until you need to speak. And if I can see everybody on screen who's on the meeting, so if you need to speak, if you just wave your hand, I'll be able to spot you. That'll work nicely for me. Okay, and we are quorate, Jackie. Yes, we've got enough
Yes.
exec and non-exec and clinicians present. Thank you very much. We were half expecting from a member of the public to be present, but they don't look to be present, but we'll address there was a question raised by a member of the public, but we'll address that later on in the meeting. Okey-doke. And formal welcomes to the new governing body members, Joe Bushnell and Alistair Johnson. And so, notification of any other business. Is there any other business that people would wish to raise that hasn't been included or previously notified? No, nothing to raise. Okay, declarations of interests. So we have a declaration of interest here in relation to Michelle Thompson. However, she's not actually present at the meeting, so don't need to worry about that. But it was a clash in relation to the fact that Healthwatch in Darlington was providing a small level of service in relation to one of the items that we'd be discussing. But since she's not present, it doesn't really concern us too much. Okay. Onto the unconfirmed minutes of the previous meeting. So, starting on page 7 of the papers, page 8, page 9, page 10, page 11, page 12, page 13, 14, 15, 16, 17, 18, 19, 20, page 21. So everybody okay with those as a good and accurate record? Yep, everybody's nodding. Yep, thank you very much. Hats off to the minute takers and nicely done. Then there was some rising, and there were 3 actions, all of which have been closed, marked as complete. Okay, go back to my agenda. Okay, so since there's nothing arising from the minutes and no matters arising or action log, next on the agenda is the annual modern slavery statement. If we can get that done quickly, and then we'll bring up Craig and Janet, if that's all right. Is that enough time? Will that work for you, Craig and Janet? Yeah, okay. So do you want to quickly do the modern slavery statement, Jean?
Yeah, thanks, Chair. It is what it is. It is a statement that we are required to make. I think it clearly sets out why we're making it. It also acknowledges the importance of it. This will go on the CCG website. This is integral to an enormous amount of work that we do from safeguarding adults, as well as sometimes children as well. And it signals our approach to modern slavery. It is similar to our colleagues, both in other trusts and also our local authority colleagues that we've got represented here. It is a cohesive approach as to how we work and address this. It is a statement, and therefore the narrative is as is.
Okay, so any questions or comments following that? Dave?
Yes, Beth, thanks. In full agreement. I noticed this does include supply chain, which is difficult when it's international. I think we were all quite distressed what we saw on the BBC News about the terrible conditions people were in certain parts of the world making PPE. And I wondered if there is any intelligence from the NHS or Department of Health to sort of flag up any supply routes which are to be avoided for those purchasing on behalf of us and the NHS in the area.
Thanks for that, David. That wouldn't be anything that would specifically come to us as a CCG, because we really don't procure anything in that sort of fashion. That would be more for NHS supply to be aware. But where we as a CCG are much more focused on this is within our localities. I think what it does is it raises awareness, because people have a view on modern slavery about it's something that happens over there, whilst they may go about their daily duties and not necessarily think and say that. But corporately, and that's the big NHS corporate, there is a tremendous amount of work behind the scenes, which is what, as you've referenced, David, some of the concerns about where we would get our supplies from. And I think that the work on modern slavery is pushing further and further, whether you want to think of it as downstream or upstream, into those supply routes to where things come from.
Thank you.
Thanks. So the decision is that we approve it or we receive it?
It's for approval, pause, please.
So is everybody okay to approve that as a CCG's modern slavery statement? Yep, that's approved. So that's for the formal record there, Jean. Craig and Janet, do you want to do your thing now, and then you can sort of scoot off when you're needing to?
Certainly can do, but it's the presentation with regard to the COVID vaccination programme overview that's down on the agenda for Rebecca Warden, but it'll be myself and Craig and Karen that are doing a bit of a triple act, if that's okay with everybody.
Absolutely, please do.
Now, conscious of time, and I know Jane will now be frantically trying to get the slides up, and I won't try to share because I'll make a muck of it. But however, understandably, I think just to lead into this, never before have I ever been involved with such a massive mass vaccination programme that's so new, moving at such fast pace. And it's just an area of uncharted territory. And as it will become apparent through the slides, if you can go to the first one, Jane, that's grand, thank you. It's a significantly complex programme with the desire to get as many people vaccinated as soon as we are able to do so. But understandably, yes, it is not without significant logistic challenges. And that's not least to say that, yes, obviously it's a very new, novel vaccine. We now have 2 that we are able to use, and that we are operating under very different circumstances to how we would normally use a vaccine in primary care. They would normally be licensed and have been around for a long, long time. However, we are where we are, and it's how we can embrace this programme and obviously recognise how important it is to the nation as a whole. So from an overview perspective, there are 4 different places that you can access your COVID vaccination. There is a mass vaccination approaches with large scale facilities such as that currently open at the Centre for Life in Newcastle and the Nightingale in Sunderland. There are the local vaccination services, which are run by our primary care networks. There are hospital vaccination services, or hospital hubs we'll refer to them as, and they are providing services for health and social care workers and other vulnerable cohorts that are able to access the inpatient vaccination from a hospital perspective. And also there is local pharmacy vaccination services as well, that have 2 of which have just come on stream in the Tees Valley area. If you can go to the next slide, Jane, thank you. Understandably, yes, this is a programme of national importance. It's a very new programme, so there are different levels of control from a national perspective, from a regional perspective, and very much at a local place-based level. Understandably, yes, it is how we try and get these to knit together to provide collaborative cover to make sure that, yes, all elements of the people involved with the programme are able to complement and work together. Understandably, it's a huge challenge, as will become apparent. I know anyone, if you turn the television on, you can guarantee there'll be something about vaccination on the television, quite rightly so, because of the vast importance of it. But from a health service point of view, it's important that we do all try and work together to coordinate the approaches, recognising that they are novel vaccines, but yes, and recognising the huge challenges with it. If we can go on to the next slide, Jane, if that's okay, just to say how we manage to keep a control at a local level. Understandably, yes, it is in all of our interests to make sure that we try and get the approaches coordinated as best we are able to do so, to make sure that we vaccinate everyone that will get benefit from the vaccination, recognising that obviously in our population, we have significant areas of deprivation. We have significant cohorts that are harder to reach traditionally with vaccinations. And it's important that we plan our approaches appropriately. From the Tees Valley perspective, we have a Tees Valley vaccination board that actually takes control of oversight of COVID vaccines and what's happening to our populations with regard to how they access the vaccine for the different sites that's available, and try and link, well, we do link in with the regional ICS vaccination board. And obviously the diagram there from a governance point of view tries to show how things are all interconnected, because yes, understandably, yes, you know, it is important that we try to coordinate where possible, and that tries to set out in a graphical form as to how we are doing that, to make sure that every person who is involved with the delivery of the programme from the PCN point of view, from a community pharmacy point of view, and the mass vaccination centres is linked in and linked together to try and keep that oversight and awareness and control. From a Tees Valley Vaccination Board point of view, many of you are also members of the ICP recovery group, and yes, you know that we update you on a weekly basis and try to make sure that we keep you linked in and aware of what is happening and changing with the programme. However, as many of you will have already heard me say, it's a programme that changes at such pace that yes, you know, we learn one thing at one particular part of the day, and then, you know, things may have evolved a little bit as time goes on, recognising the need for us to adapt and change and be fleet of foot with the programme that she's trying to develop as we go alongside delivering it. If we can go to the next one, please, Jane. Thank you. Understandably, it's a very complex programme, and yes, a lot of significant thought has gone into who we need to vaccinate first. The patient priority groups listed in front of you are composed and compiled by the Joint Committee on Vaccination and Immunisation, which is an authoritative body that makes decisions on such things, with a variety of eminent people making these decisions. And yes, the first 4 cohorts that are outlined on the slide in front of you show that the target for us to have achieved vaccination for, or offered vaccination to, by the 15th of February are those adults in care homes and their staff, and over 80s and frontline health and social care workers, and those in the over 75 and over 70 years of age, and are clinically extremely vulnerable cohorts. The cohorts 5 to 9 are of the younger age ranges and people with additional risk factors. If we can go on to the next slide, Jane. Now, I appreciate I've rushed the slide. If there'd been members of the public, I would have taken more time going through this one. But if we can go to the next one, because understandably, it's awareness of why the JCVI have chosen those cohorts. The evidence is that, unfortunately, increasing age is the major risk factor for mortality from COVID. And because of that, that is why the JCVI have listed their priorities in the order that they have, recognising that the older cohorts are those at highest risk. Understandably as well, it was clear from very early on in the COVID outbreak that unfortunately residents in care homes were at a significant risk, hence the need and the identification of especially older adult care homes to be prioritised for vaccination, and indeed recognise that frontline health and social care workers are at increased risk of contracting COVID, but also are at increased risk of actually transmitting it when they're asymptomatic and don't realise they're spreading it to their vulnerable clients or patients that they are caring for. So if we can go to the next one, Jane. That's the rationale as to why those groups have been chosen for vaccination, but just a few little wee handy figures to get in your brain as to get it home, really. We know that the priority groups that are in the top half of the priority actually make up 99% of the observed COVID deaths. So it makes perfect sense for the JCVI to have chosen those cohorts. And if we vaccinate care home residents, vaccinating 20 of them will actually save 1 life, which is really quite significant. And if we include care home staff and residents, vaccinating 40 of that combined cohort saves 1 life. In those over the age of 80 living in the community, vaccinating 160 of those patients will save 1 life. So there's some quite startling figures that actually does help to bring it home as to why those cohorts are being prioritised, and indeed why some people have had to be asked to wait for their vaccine. If we can go to the next one, Jane, if that's okay, thank you. So understandably, yes, there's been a lot of changes as the programme is developed and enhanced. In general practice, we're used to providing flu vaccination on an annual basis, and it was initially thought when the COVID vaccination programme was coming out that it would be handled by mass vaccination sites alone. But actually, as time evolved and as the vaccine data and information became available, actually it was decided that it was needed to be needed to be changed with how it was going to be delivered, and delivery was to move into primary care involving the primary care networks, recognising that because of the nature of the vaccines available, you have to do it differently because of the multi-dose vials and the complexities of how you have to handle the vaccine in a very different way. Suffice it to say that locally our PCNs have really responded to the significant challenge of delivering this exceptionally different vaccine, and their response has been and continues to be very, very, very amazing. They have been making remarkable progress in delivering what is a very, very complicated but essential programme. If we can go to the next one, please, if that's all right. Thank you, Jane. An ongoing process was put in place to make sure that, recognising that this is a new vaccine, that the way it has to be delivered has to take into account the different natures of the vaccine handling, as well as the fact that it needs pharmaceutical oversight. There had to be site readiness to make sure that the sites that were going to be delivering the vaccine were appropriate for that to be done, that the pharmaceutical assurance was there with recognising that this was the authorisation of the viruses, authorization of the vaccines, if I get it right, had to be done under specific circumstances, and we were following a very methodical process through it. 14 sites across the PCNs were approved across the Tees Valley, and as I say, yes, mentioned, the Herculean effort of the PCNs, was duly noted, with the desire to make sure that they would want to step forward to vaccinate their patient cohorts. Great to know that the second vaccine became available towards the end of December, and that gives greater flexibility to be able to vaccinate patients in a care home setting, because the vaccine is much more mobile and more movable, and indeed also be able to extend it to over 80-year-old patients who are in the housebound setting, which the Pfizer vaccine earlier, because it doesn't transport well, wasn't able to do so. Understandably, the Moderna vaccine has also been licensed, but isn't currently in use in our vaccine programme as yet. If we can go on to the next one. Thank you, Jane, that's grand. Understandably, things had to happen in waves. The vaccine supply chain and the supply chain for the consumables associated with being able to deliver the vaccine does take time. I entirely appreciate everyone's frustration that, yes, everybody wants it now, and I understand that, of course we do, but it had to be done in a planned phase, staggered way, recognising that this was a very new, novel approach, and it had to be done step by step, which obviously it was across the Tees Valley and nationally and regionally. The vaccines are currently being supplied to the PCN sites on a push model. What that means is that the PCN sites, once they've been authorised, and all our PCN sites are now live, they receive vaccine on an allocation basis and are told by NHS when the vaccine will be allocated to them and when it will be arriving and when it will be delivered. And because of the shelf life of the vaccine when it is stored from the Pfizer perspective, that dictates very much the time period that they are able to give that vaccine. Understandably, even the AstraZeneca vaccine that is more stable and has a longer shelf life, the imperative is that, yes, we don't want it to be sat in shelves in fridges. What we want it to be doing is being administered to patients. So significant logistical challenges, but yes, ongoing at pace. And if we can go on to the next one, and I'm so sorry, Karen, these are your slides, so I will stop and let you join in. Sorry.
I just thought you were
carried away with enthusiasm. Sorry, Karen.
Yeah, 3 slides ago, Janet. Thank you. So in terms of, it's probably just to pick up some key points in terms of those who might not be as involved in the programme. In relation to the enhanced service that's gone out to practices, it's every practice has to sign up to the enhanced service, which they have, and we've had a great response from all of our practices. For those of you that may be new to the governing body, and certainly for public members, primary care networks are groups of practices working together. They're not legal entities, they're not organisations. It's about practices working in groupings to be able to deliver a service. So that's where our practices have come together to deliver the service of the vaccination programme that they've all agreed. In relation to the designated site process that Janet's described, I think we need to be really clear. These sites are determined by the primary care networks to meet their population needs within their groups of practices. The CCG and NHS England obviously had to sign those off to make sure that they were ready to mobilise and that they were designated as a site. Practices aren't able to deliver from alternative sites, only from those designated sites, unless it's within a care home or for housebound residents. So we've had some fantastic offers from the community in relation to utilising additional sites, but currently as it stands, we have to use the designated sites that have been agreed by NHS England for the use of the vaccine. The practices also working in their groupings have to be able to deliver potentially a 7-day service from 8 till 8 to make full use of the vaccine and utilisation of it. So I thought it'd be helpful for members to better understand that. Over the next few slides, and I won't go through them in detail, it describes the waves that Janet's outlined in terms of the go live date. So we started on the 14th of December with our first network and group of practices working together, and that continued right through till January to our 6th wave. And we've provided those slides in the groupings for the practices that are working. So if you could move on to the next slide, Jane. So each of the areas have a number of sites. Obviously there's 13 across our area, and I'll pass on to Craig because Craig's going to pick up the data because he's been working with our teams around data, and then I'll speak again after Craig's finished.
Cheers, Karen. Thanks. So I've just got a couple of slides now to try and give an overview of where we are in terms of some of the numbers, the number of vaccinations that have been delivered. I think it's probably important to start by saying that the data that we're using for these two slides has been sourced from the NHS England COVID-19 vaccination statistics webpage, which is a publicly available data source. The actual data within there comes from the National Immunisation Management Service, NIMS, and the figures are subject to change and refresh. So there is a caveat on any of the information that's shared. The presentation, or the two slides, were based on the latest available information at the time the slides were pulled together, and I'll talk you through some of the process, but in essence there are two data feeds that we can pick up at the moment, a daily and a weekly one. It is an evolving data set, so additional data items, levels of granularity are likely to be shared over coming days and weeks, but this is what we've got at the moment. We don't have access to CCG or PCN level vaccination numbers, so I've given you what we've got available to us. The two feeds are a daily feed broken down by region. For us, that would be North Eastern Yorkshire, and a weekly feed broken down by ICS STP. So for us, North East and North Cumbria Integrated Care System. Okay, this first slide is a summary of the daily vaccination data. And it was produced on the 23rd of January and basically sets out where we were at that point in time. So the cumulative position for our region was just short of 1 million vaccinations. That's set in the context of 5.5 million nationally, and our region was delivering around 73,000 vaccinations per day as at the 23rd of January. That shows a steady increase from the 18th of January, where we're just over 25,000 up to that point in time. So great progress over that period, which fits with the rollout plan that Karen's just talked us through. Using the notional target of around 2 million vaccinations per week in order to meet the government commitment around vaccinating the 9 priority groups, there is a proportion of those 2 million per week vaccinations that our region would need to undertake, and that's indicated by the dotted green line on the graph. So you can see that at this point in time, the 23rd of January, we were more than delivering our contribution towards that notional target. Okay, if we could move on to the next slide, please, Jane, if possible. This slide basically gives an overview of the cumulative comparison of vaccinations as at the 18th of January by ICS, Integrated Care System. You can see that our ICS is indicated by a grey bar, the other integrated care systems in our region by orange bars. I think what's worth noticing on this one is that for the North East and North Cumbria, we're in the upper quartile for both of the measures reported. So the proportion of population received their first dose and the proportion of the 80+ population that have received their first dose. So we're doing well in comparison to other STPs and regions. The North East and North Cumbria ICS is also the best performing part of the North Eastern Yorkshire region. So again, we're at the forefront. That was based on the daily information at the 18th in terms of the data. So I was going to hand back to Karen. If we can bring the slides back up, Jane. Thank you.
Next slide, please, Jane. So I think one of the things with this programme, because it has been so fast paced, is making sure that we've got the communication and the links to the wider system, as Janet had described earlier. So what we're trying to ensure is that there's regular communication through the different boards and groups that are already in place, but also most importantly to provide our primary care networks and our groups of practices information. So at the moment, our primary care networks receive regular updates from NHS England and NHSI directly, but we also follow that up from a CCG perspective to make sure that all practices are aware of the programme and what's happening around the programme. At the moment, as Janet said, there's a number of, it's really fast paced and there's lots of change and lots of documents are being issued throughout the week. So what we're doing is we're consolidating all of those documents into one report and providing that during the week to our primary care networks and also through to our integrated care partners through the ICP meetings that we have to make sure the whole system's cited, not only on the requirements that are being published from a PCN perspective, but from the wider partners perspective. And there is also a daily reporting process now in place for care home residents being vaccinated, and that is being implemented. Next slide, please, Jane. So one of the key pieces of work, because our system partners in our hospital trusts are responsible for the immunisation of health and social care workers, and Janet, as our medical director, and our medicines optimisation team have led a piece of work in relation to making sure that we're able to bring the system together and put processes in place to manage, to communicate on the vaccines that are available within our localities and how we can ensure the prioritisation of the health and social care workers. And again, those updates are provided through the vaccination board, and there's joint working through the vaccination board with our partners to ensure that there is a joined up system. We are now receiving a delivery schedule of planned vaccines into the area from our ICP perspective, and we're working with our planning team to ensure that we're able to ensure the appropriate cohorts that are being announced through the JCVI cohorts that Janet provided an overview of earlier, that we've got enough vaccines coming into the area. And as Craig said, we're doing really well from a North East perspective and a local perspective in terms of our vaccination programme so far, and the work across our wider system and partners with our primary care networks has been phenomenal in the last 6 to 8 weeks. Next slide, please. One of the key things is around public messages, and there's lots of confusion currently in relation to the messages in terms of COVID vaccination. There has been a communications pack that's been developed across the North East that provides key messages, links to campaigns and other materials that are available, and the resources and contacts for individuals to make contact. I think one of the things that we're trying to do at the moment is manage expectation. The practices and the PCNs can only provide the vaccinations for those cohorts that have been announced by the JCVI. So on the earlier slide, you will have seen cohorts 1 to 4, so that's your 80s, your care home residents and staff, your 75 and older, and your 70s and older are the cohorts that have now been announced to be called forward for vaccination up until the 15th of February. And that's the work that our PCNs and our wider partners are undertaking in relation to vaccinations. But that has caused confusion because people are being called at different times from their practice, and it's been managed by the primary care networks. So key messages are really important as we move forward through our social media channels and also through our local press to avoid confusion for the public. Next slide, please. So an example of our patient messaging, which is really key, is that people will be contacted. People will be contacted at different times, even within the same age groups, as it depends on the prioritisation process that's been put in place by the practice and the number of patients that have within that cohort. So what we're asking is for patients to await and they will be contacted by their practice or by their primary care network in the coming weeks. And we're asking patients not to contact their practices directly at the moment to try and ensure that they're able to concentrate on their day-to-day work as well as the vaccination programme. And we need to make sure that we keep our practice telephone lines free for those people that may need urgent care during this period as well. So we are asking the public to keep calm, and be patient. We are absolutely assured that your primary care network and your practices working together will be calling patients forward. Next slide. So it's over to Janet to pick up the next few slides.
Now, I do beg your pardon, Pos, because yes, this isn't strictly COVID vaccination programme, but understandably, we've been asked to provide a quick little update about other COVID-related issues, one of which is COVID oximetry at home. Now, I appreciate that with the audience that we currently have watching in the room, many of us are already aware of the COVID oximetry at home programme. Jane, if you can go on to the next one, thank you. But for those people that aren't, it's a way of us monitoring patients in their own home who are COVID positive for up to 14 days of their illness to make sure that we can identify earlier when those patients are deteriorating with something called silent hypoxia that you can pick up with a simple piece of plastic equipment that we can then monitor with our remote monitoring service to try and be able to intervene earlier, which has significant benefits from the patient point of view because their experience is better, they have reduced mortality, but also from a system point of view has the ability to make sure that those patients that can be safely managed at home are managed at home in a safe environment with appropriate safety netting. But also, next slide, Jane, if we can, thanks. But also enables us to benefit the system by making sure that those patients are able to go home from hospital sooner, are supported to do so, and make sure that, yes, we can complement what we can do in our COVID oximetry at home service from a community point of view with the specialist virtual ward, which is provided by the secondary care end, where those patients with pre-existing respiratory conditions that may affect their oxygen saturation, or if they have any pre-existing oxygen requirement at home, the specialist teams within the hospital setting are able to monitor that, and we can do a complementary service. So we have the community COVID oximetry at home service that we've talked to you about previously, that was a pilot in the Tees Valley, but also now coming on stream across the Tees ICP, the specialist step-down services that the hospital trusts are also able to offer as well. We use digital technology, and that's not to digitally exclude any of our population, because even those without access to the technology themselves are able to be supported by the remote monitoring service, who will enter the information onto the digital app on their behalf. If we can go on to the next one, if that's all right, Jane, thank you. Our current referral criteria, as is described, which again reflects the fact that we know that our patients of older ages unfortunately have worse outcomes from COVID, as do patients who have pre-existing health conditions, which reflects the patients that we select for the enhanced monitoring of the COVID oximetry at home. If we can go on to the next slide, please, Jane, if that's okay. The reason I'm not labouring that is because national guidance for the programme that started out in Tees Valley as a pilot is now nationally in place across all of England. And yes, there are further changes coming, like COVID vaccination. This is another area that is rapidly developing and evolving in response to what we learn more about the virus. And yes, the referral criteria, may be set to have further changes. Ultimately, so far, we know we've had just over, actually that figure's slightly out of date now, because we've had quite a few more than 600 patients now through the service from the community COVID oximetry at home programme, and patients are feeding back very, very positively. The staff find that it is a very useful service because they know they are benefiting these patients. The patient experience is better. We know patients are in hospital when they have to be admitted for a shorter length of time because we've responded sooner. We know our rates of mortality are significantly lower on the virtual ward than they are without the additional monitoring. The evaluation is still ongoing and is part of an evaluation with NHS England and NHS Improvement and NHS Digital in partnership with colleagues from UCL, and there will be further information that we will glean as we continue to monitor large numbers of the patients through the programme. Now, forgive me, I've rattled through conscious of time, Pos, and I know obviously many people here already know most of that information, but for those members of the public who will watch afterwards, hopefully they'll be able to read the slides. Thank you, Pos.
Thanks, great. So that does give us a little bit of time to have questions on this that need to be answered by you and Craig. And then we'll move on to Craig's presentation about performance. But I'll do questions on the COVID issue first. Jean.
Thanks, Pos. It's not really a question. It's more a little bit of good news to share with colleagues. So colleagues who've been involved in this presentation have been very, very factual. However, I would just like to give them a bit of praise that's come not from me, it's come from patients who are involved in going through this. Universally, I have only heard good things from patients, which is a wonderful thing, because I am the person who any bad news from a patient perspective or patient experience always makes its way through to me. So to actually have universal positive feedback from patients who go through this process is wonderful. I think it's a phenomenal positive reflection on the work that's gone on behind the scenes to actually the logistics and everything and to put this in place, as well as on the people who are delivering the vaccines, excuse me, to the patients face to face. The stories that you hear from people who've been through this are really heartwarming. They're tremendously impressed at the efficiency. I tend not to tell them that that's due to infection prevention control mechanisms, because they just think it's military efficiency and it's fantastic. But also individually, they talk about their experience of the person who vaccinated them in absolutely glowing terms. So I think it's important that we acknowledge the work that's gone on. We've had all the detail, but what this is meaning to patients is phenomenal. And I think that the governing body, to thank everybody who's involved in that, I think it's really a tremendous positive story in such a very difficult time. Thank you, Pos.
Thanks, absolutely. And on top of that, it is absolutely everybody across the system involved in delivering this. So not just practices, it's all the other sites where COVID is being delivered as well. And it isn't just the clinicians and the delivering the vaccines, it is all of the support structures that, like the pyramid, the sturdy pyramid below the pointy bit with the sharp needle at the end, that is helping to deliver the system that makes the COVID process work well. And not only have patients been thanking practices, but actually I have been hearing of practices thanking the CCG and the CCG staff for the support that's been put in. And it's not just the CCG, NEX has been doing a lot of stuff in relation to making sure all of the information technology systems are working in the background. So everybody has been mucking in. So formally, the CCG needs to record its thanks to everybody involved in any slightest aspect of making this work, because all the cogs need to work together to make the machine progress as well as possible. Now, has anybody got any other specific questions for the next 5 minutes in relation to the COVID stuff? I've got a couple of things to pick up, particularly in relation to public experiences and what's been raised in Michelle's report to the governing body, and with Michelle not being here, I thought it would be useful to raise this. A section of a paper dealt with people having queries in relation to the COVID vaccine, and potentially some half expecting to have been communicated about when they're going to be called in for their vaccine. So the wider question is, what is being done in relation to comms to facilitate the public understanding as to how and when they'd be getting their vaccine and who to contact if they have queries? Because there's a huge amount of pressure on practices in relation to number of phone calls being made for queries that potentially could be handled elsewhere. Probably over to you, Janet, first, and then Karen and Craig.
Yeah, I mean, suffice it to say that, yes, understandably, I appreciate why all members of the public are wanting to know when their own vaccination is going to be due, but we are encouraging patients to, if where possible, not contact their GP practice. Where possible, recognise that the NHS will be in touch with them when they are due to be called for their vaccination. Now, I appreciate that the numerous different points where they may be called to doesn't necessarily help, but yes, the NHS will be in contact with them, be that their practice that will be in contact with them for the primary care network vaccination, or be that for an opportunity via the national booking system for an appointment at a community pharmacy setting or at a mass vaccination setting. We are working very closely with our comms teams on a national basis, on a regional basis, and a local basis, and very much, we are trying and quite rightly sticking to the nationally agreed, regionally agreed messages to make sure that we're giving that consistent approach, so that everyone gets the same information no matter where they ask the question. For those that are digitally enabled, there is a lot of material available on the Gov UK website in general about vaccination, which gives people a chance to answer some of those questions or comments that they've got. But from a myth-busting perspective, there is a need for us to target particular cohorts, and we've been working with some of our social care colleagues who have particular issues with regard to questions around a myth about effect on fertility, of which there is not any effect on fertility, and making sure that those who have allergies feel assured that they know where to get the right information about which vaccine type that they are able to access. And it's just encouraging those consistent messages, and local comms are producing information on a social media basis, using media channels such as radio and television as well, in addition to getting those messages out. We've had our local GPs, local pharmacists on radio and television to try and provide some extra information about and reassurance about the vaccine programmes. I'll pass to Karen for elements that I might have missed there.
Sorry, just before Karen comes in, James, you had your hand raised briefly.
Yeah, I was just going to say that I think most of the queries that I get are more from patients wanting to make sure that they are vulnerable and trying to push themselves up. But there was one group of care workers who I wasn't quite sure about, and those are care workers who work in non-NHS or sort of private hospital type facilities. So we're talking about your Priory and your Signet type things, and they were not sure how they could access theirs.
And indeed, yes, whether you work for an NHS organisation that deals with frontline health and social care or not, you are covered by the desire to get all patient-facing individuals vaccinated. So yes, whether you are a private provider or an NHS provider, you will be called. And I'm delighted to say that the organisations you've mentioned, I know I've personally helped to book some of them into appointments, so I know that they're getting through, definitely.
And it's worth recalling that those organisations are providing a fair amount of NHS-based care provision at the moment, which the NHS has shifted over. Sorry, Janet, I'll need to cut off this to allow Karen a couple of minutes and then for Craig to come in 2 minutes. Karen?
Yeah, it was just to pick up on what Janet had said in relation to the comms. So all of the comms are being managed locally as well through our comms team and through our social media channels. And one of the things that's also happened is we've liaised with every health watch to make sure they're clear in terms of messaging. Dave's also contacted all of our local MPs to make sure that they're aware also, because what we do need is we need consistency in message and approach, because we're all receiving queries from different areas. And we all need to be making sure that the public are aware they will get a vaccine if they're within those cohorts that have been identified. They will get called, they'll get called by the NHS, and their practice will be working to ensure that no one is missed. And we've had assurances from all practices in relation to that, but you may not necessarily get it on the same day as your next door neighbour, because it will depend on how you're being called forward, but you will get called. And I think we need to keep on reiterating that message. And in terms of the independent sector, obviously that's the work that I alluded to, that both Janet as medical director and Al are facilitating in relation to ensuring that there's a coherent list of those organisations where staff may need vaccinations to ensure that they're directed to the appropriate vaccination centre. So that's the work in terms of assuring the governing body that that is continuing as well.
Right, thanks, Karen. If there's any other questions in relation to COVID, we'll pick them up after Craig's done his bit about the performance, because he needs to go now, with Karen and myself and Dave and anybody else who can answer questions as and when needed. So over to you, Craig, to do the bit that you need to get done before you leave.
Cheers, boss. Thank you very much. Okay, so in terms of the performance update, the performance slides are included in the pack, starts at page 89. If we can go straight into slide 91, which is the current activity where we normally start. The performance position as reported in the pack is covering the November-December period or time period. You can see from the percentages quoted across the 3 provider trusts that we've started to see a significant reduction compared to the same period last year in performance of both outpatients, inpatient and day case activity now, and that's a direct result of the COVID surge that we're seeing. So COVID surge in admissions, IPC restrictions on beds and capacity within the trust, sickness of staff resulting from COVID, reducing the ability of the trust to respond in a planned way, and planned reductions in the elective programme during December over the Christmas period ahead of winter pressures and the anticipated further surge of COVID that was anticipated. As of December, the available surgical capacity within both the FTs and the IS is being reprioritised around the most clinically urgent patients. So traditionally they'd be the P1s and the P2s. And there's quite a bit of work that's been going on with the independent sector to prioritise cancer patients, and I'll touch that in a further slide. If we could move on to the next slide, it's page 92 of your pack. Key performance issues. Again, we've focused in on two key areas: RTT long waits and cancer waits. The referral to treatment position, the RTT, continues to be significantly challenging. We've had over 5,000 breaches of the 52-week wait standard. Last year, we'd have only had 4. That doesn't directly relate to 5,000 patients currently waiting over 52 weeks. I need to make that clear. We've currently got at South Tees FT 1,500 patients waiting over 52 weeks, over 990 at County Durham and Darlington Foundation Trust, and a very small number at North Tees. But the way that those patients are reported, each month that they breach, they attribute a breach. So one patient can appear multiple times in the reporting. That said, it's clearly not a position we want to be in. When we look at the national position, we do benchmark well. We have less 52-week waiters per 100,000 head of population than other areas, but again, still not an acceptable position that we want to be in. We are continuing with the harm reviews.
Craig warned us that he had a dodgy audio link. Oh no.
For all long wait patients, just looking at those under, and we look at wait cohort. Sorry, did you want to come in there, Paz?
No, your audio went.
Sincere apologies. Okay, I'll keep going in.
Yeah.
Hopefully it will catch up. In terms of cancer, in terms of cancer, we're trying to maintain the cancer program as best as possible. The FTs are currently working to make sure that they're not cancelling any cancer patients, and they're looking to work with the independent sector to move patients out wherever possible. Ramsey are supporting with urological and gynae cancer surgeries. Nuffield are supporting with breast, and the Woodlands have recently agreed to take on some skin cancers. That means that they're not moving forward with routine P3 and P4 procedures. So the likes of the routine orthopedics has been paused for now, while we concentrate on making sure that these cancers can continue. There is daily reporting in place for any cancer patients who are cancelled, and all FTs are expected to rebook those at the earliest possible opportunity. And across our ICS, additional work's been undertaken to source endoscopy capacity to support the long waiters at County Durham and Darlington Foundation Trust. If we can move on to the next slide. The next slide just details some of the mitigations, some of which I've talked through, others we've just discussed previously. They are there for the board's review and comment, but I wasn't planning on talking through those in any detail. In terms of the next slide, independent sector activity, I've touched on how we're trying to work differently with the independent sector now. We have a contract in place with them. It's a nationally set contract. That capacity is there, and we're trying to make the best use of it. We have submitted revised plans for Q4 as to how we would like to work with the independent sector, clearly depending on the pressures in the acutes and the need to move some of the higher priority, higher clinical urgency work out. Those plans may change, but we'll just continue to update the governing body as those plans evolve and develop further. What's pleasing to report is that the FTs and our independent sector colleagues are working very closely together. So there's a seamless transition between patients moving from one setting to another, which is great to see, really. Other than that, I've attached the usual performance report appendix, which details performance across all of the constitutional indicators and a whole suite of other KPIs that we report on. Wasn't planning on talking you through those, but more than happy to take any questions, Paz.
Okay, before anybody asks any other questions, can I just verify that the ICP, the independent sector contract that we have to shift some of the NHS care into is being used to its maximum capacity or as close to that as possible?
Yeah, so absolutely, that's our aim. The capacity is, I suppose it can be viewed in a number of ways. There's physical space and there's staffing. And whilst the independent sector offers additional physical space, it doesn't always come staffed. So we're having to work really closely with the FTs and the IS to make sure that we've got staff who can work in these facilities as well. So where possible, we're absolutely maxing it out. That isn't always possible because we haven't always got the clinical staff to do that. A good example would be around anaesthetists. There is a shortage of anaesthetist cover, and we've got people working in the acute at the moment supporting patients who are in critical care, as opposed to supporting surgery of those patients that perhaps haven't got the same level of clinical needs. So the P3s and the P4s are just being put on hold for now.
Okay, thanks, Craig. Anybody else got any other questions? No. No, well, thank you very much. We'll let you get off a few minutes early.
Thanks, boss. I will rejoin in about half an hour's time, so thank you. Cheers.
Great. Right, thank you very much. And Janet, I figured that you probably have covered your major things that you'd be reporting in the locality report, is that right?
Yeah, absolutely. I mean, suffice it to say, the practices are working exceptionally hard amongst some quite complex workforce pressures with regard to staff that are either off with COVID or self-isolating. But I know Karen will be able to pick up any of those elements or questions with regard to that, Pos. Thank you.
Okay, so I'll let you get off as well. Okay. Has anybody got anything else that they want to raise as queries or questions or observations in relation to either the performance or the COVID vaccination process? I've got one point to sort of formally check, but I'll, so, no, Karen, no, Mark, no, right, okay. Can we just quickly, and probably be useful to have your public health viewpoints, touch on the change in the schedule of the second vaccine that's been nationally directed, and seek partly assurance that we as a CCG are absolutely maximizing the possible numbers of first dose recipients that we possibly can, because there is a very good rationale for delaying the second dose at a time when we've got a shortage of vaccine in the system. Esther and Craig, do you want to, have you got any observations about the second dose?
Sorry about that. Just trying to unmute.
Yeah, absolutely.
I'm not a user of Zoom very often, so
we all get caught out in the I'm on mute problem.
Yeah. So in terms of maximising the use of the initial vaccine doses, yeah. I mean, obviously, I think it's obviously very fairly well documented, the rationale behind that, and I think you know, from the JVCI point of view, you know, I think it's an appropriate thing to be doing. You know, as I say, I don't have got enough information really at the moment about the uptake to give an opinion at this point in time around how that's going locally. But obviously, that's one thing we're trying to keep a you know, firm eye on, in order to make sure that the inequalities aren't increased, for example, through this process.
Dave Gallagher.
Thank you, Pos. Just, is the microphone working now? Because I just switched
yeah,
the
we just hear you. Yeah.
Yeah, good. Thank you. I don't know if anybody caught it yesterday, but I think it was yesterday. Chris Whitty was on the TV talking about the rationale, and he was really, really clear about this. The idea of the dose.
Dave, you're getting very difficult to hear again.
Geez, I've obviously got computer problems.
Really lean close.
Yeah, ignore the close-up view, please. So Professor Chris Whitty was on the TV, and he was really outlining the absolute benefit to focusing on maximising the first dose for people, because you can, and it's obvious really, you can actually inject twice as many people by focusing on a first dose without too much of a detriment. And we've had national direction to do that, so we've passed that on through the primary care networks. And apart from the very, very first week before this was made public, everybody now is receiving the first dose. Nobody is receiving the second dose until they're required to, according to the new regime. So I think it's debunked the reasons why, you know, what's right and wrong with this, but equally we're really, really adhering to this.
Thanks, Dave. Yeah, and there was actually somebody did a very clear example on the news last night as to the significant benefit of the second dose not being administered immediately in relation to the numbers of people who can actually get covered with a first dose. So if you had 2,000 vaccines available and you gave 1,000 people their 2 doses, you'd get 950 people vaccinated. But if you had the 2,000 vaccines and you gave them to 2,000 people, and even if those vaccines were only 60% effective in that first dose, which they're not, there's indications that they're significantly more effective than that just with 1 dose, you'd have vaccinated 60% of 2,000, namely 1,200. So effectively, by the current process, you're getting at least 1/3 extra people covered. And if you think back to what Janet was saying in relation to, for every 20 really elderly, vulnerable, frail people vaccinated, you're saving 1 life. It means that ethically and morally, the only thing that we can be doing is doing as many first doses in the present circumstances as we can. And it makes me feel very comfortable from a professional point of view that we're doing that. But it's really just verifying with, for example, Karen and Craig, that we're doing whatever we can from the CCG perspective to facilitate that process. You've done it as well, Karen.
Yeah, sorry, I couldn't find. I think in terms of assurance to the governing body, we're obviously working very closely with the regional team and the national team in terms of the vaccines received into the area. And for reassurance, we are working with our primary care networks to make sure that the correct cohorts, in line with the guidance that has been issued by NHS England and also by the JCVI in relation to first doses, and the interval in the gap between first and second doses is being adhered to. And that's in line with national direction. So we're assured from all of our PCNs that first dose vaccinations to ensure the maximum number of vaccines can be provided are being provided currently. We're also working with the primary care networks to make sure that we manage expectations of patients in relation to that new guidance that was issued at the beginning of January, to reassure them. And we're working with the PCNs in terms of moving forward around the vaccination programme itself. But all of our PCNs are working in line with the cohorts 1 to 4, as was described in the JCVI cohort, so 70 plus. And that's what they will continue to do, because that's what's been advised by NHS England, and all of our PCNs are adhering to that. So I can reassure the governing body that we have checked that and that they are following what is set out nationally.
Okay, thank you, Karen. I think we'll, unless anybody else has got any other queries or observations, we'll leave it at that. And then, oh, sorry, Hassan?
I think it's important that we highlight how hard all the sites are working to make sure we're not wasting any doses, and as well in terms of having people on standby ready to come at short notice. And anecdotally, we've seen very, very little wastage from any of the vials, really, where I've been working, and similarly from a lot of my colleagues that I've spoken to, that really are trying to maximise every single dose that counts. And I think it's excellent that the way people are working from the council, collating lists, getting people ready, helping them get down quickly at short notice. It really is remarkable how well people are doing.
And the level of collaboration between council officers in places, etc., with the facilitating sites working, etc. So yes, Jean.
Yeah, Pos, I think just on the back of what Tahir's talked about, I think the other thing as well that is quite astonishing and most welcome is obviously we've got these extended opening times. We're used to patient choice, and we're used to trying to accommodate patient choice. But our patient population is so grateful that if you say this is your slot, they just go, thank you very much. There's very little, oh, well, I can't make it then. Could you possibly make it then? and sort of wafting about. People are taking the first slot that they're offered, which is helping enormously with the logistics as well. So I think that's tremendous. Oh, it looks like Karen's going to say something different.
No, not something different at all, Gina. I think what I was going to say, I don't think we can underestimate the level of collaboration that's happened across partner organisations in terms of the offer and use of buildings, the collaboration in terms of supporting logistics, marshalling, the collaboration in terms of offering workforce, if that's available. Some of the constraints we've had is in terms of the designated sites, in terms of the offers that we've received, but they've been gratefully welcomed. And I think, you know, across all of our local authorities, working with the directors of adult social care, our directors of public health, there has been an absolute collaborative approach, including, you know, other agencies, and we'll miss some if we mention them all, but the fire service, the police, a number of agencies have offered support in making sure that the vaccination program's a success. So the collaboration across the patch, it's one programme, I think, that has absolutely brought a united front together across health and social care and much wider partners. And I think, you know, we can only commend our practices for the work that they've undertaken and our partners over the last 8 weeks, because it has been phenomenal, as I said earlier.
Okay, so thank you very much. I think we'll now rejoin the sort of flow of the main agenda. So I'll very quickly do my chair's report. We've already touched on a lot of the significant things that I was going to mention in it. So I think the only things that I'll really highlight is that obviously we've had this major flare-up of our COVID need to deliver care since our last governing body meeting. And sadly, we do need to note the recent 100,000 people died of COVID, of the latest figures since the start of the pandemic. So formally, we need to note that our thoughts are with the 100,000 families and friends and relatives and carers of all of those people who've sadly passed away. So we've already touched on the other main matters in relation to the level of pressure on primary hospital and social care as well in relation to all the COVID, so I won't do any more of that. We've touched on the positive side of things in relation to the COVID vaccination program and the amount of effort and collaboration that people have put into getting it off the ground and running increasingly well. So the only other two things to very briefly touch on, we have had feedback from the council members of the clinical commissioning group in relation to the ICS proposals. So we've taken account of that in our feedback. And we also, Janet and I both attended various LMs, local medical committee meetings relating to this, to also sort of enhance our understanding of the practices, feelings in relation to the ICS. And basically what we were feeding back was effectively in parallel to what the practices and the LMCs are going to be feeding back. And lastly, once again, formal welcomes to the governing body for our two new members, Joe Bushnell and Alistair, for our two new non-executive members for the governing body. And that's it, unless there's any other questions. Any questions rather, I'll hand over to Dave for his report. Yep, over to you, Dave.
Thank you, Pos, and I'll not go through the report as it's written. I'll probably just pick up a couple of points. The obvious bits, the COVID response, which I think I've got as one paragraph within there, just to reinforce the message that actually the primary focus for us as an organisation for the NHS and social care is twofold. One is dealing with the surge and the pressure that COVID patients are causing the system, and the second one, which we've just rehearsed, is the vaccination programme. This has been highlighted in a letter that's come to all foundation trusts and CCGs from Amanda Pritchard, who is the Chief Operating Officer for NHS England and Improvement. She wrote to us all yesterday, outlining, standing a number of things down, the focus being, as I've described, on the COVID response, pulling back from meetings. So there's a piece in there for foundation trusts about not having face-to-face board meetings, not having face-to-face governors meetings. Same applies to the CCG, and there's a couple of paragraphs in there based on CCGs asking that, and we're doing this, We make sure that we have a focus for our clinical staff within the CCG on the COVID response, and that we free up as much time and space as we can for clinical colleagues, including colleagues on the governing body, to focus on patients, and that we make best use of our non-clinical staff to support those twofold approach. One, the vaccinations, which we're obviously doing, as we've heard, and one, the response from partner organisations, which we're very much into. Probably the last bit just to finish on, and that's the bit about vaccinations, and it's kind of been touched up in the previous conversation, but a number of us are having a number of conversations with elected members, be they MPs or council leaders, and just to amplify the message that we heard earlier from them, they are very, very appreciative and welcoming of the huge amount of time and effort everybody's putting into vaccination, but also the response to COVID. So I think it's just worth sharing that with everybody, because I know they'd want me to as part of this meeting, as an ambulance goes by. Happy to answer any questions, Pos, other than where the ambulance is going.
Yeah. Okay, so anybody with any questions or observations for Dave? No. Okay, thank you very much. Janet's already effectively covered her locality update. I alluded to the particularly significant bit of Michelle Thompson's patient and public involvement update. I know that Alistair, who's unfortunately left at the moment, found it particularly interesting and illuminating to get that sort of level of detail particularly from the local health watchers. Does anybody want to pick up anything from Michelle's locality report? Apart from that, everybody's mind is presently on COVID and COVID vaccination, basically. Hi, Alistair. Managed to make it back. Great stuff.
It's all right. I couldn't source out the background, so I switched the camera off. No, just reading through the updates for the Health Watch. I thought that was illuminating, and certainly something I will certainly pay more attention to in the future. Is it available for the normal jobbing GPs to see, or is it just something that we see within this?
Well, it's part of the public papers, so it's absolutely available publicly. I mean, if you figure it'll be useful, if you sort of contact Jackie as to who to or which practices or everybody to send it out to, or which sections of it may be particularly useful.
We could send it to you as a separate document if that would be helpful, Alistair.
Yeah, thanks. I think with the COVID pressures and the fact that most of our patient group aren't that responsive to new technologies, it's been quite hard to engage with them. So any sort of feedback from any of our sort of our patients is really welcome. Obviously, we're trying hard to service a demand and through different ways of engaging patients, but I think this sort of feedback is really useful, and be a nice thing to feedback to the team as well. So, thanks.
Okay, we'll do that. Thank you very much. Anybody else? Any other questions or queries before we move on? Yeah, Caroline.
Hi, Paul. I can't find the particular page, but when I've read the papers, I've made a note about the 70% reduction in health appointments being kept by SEND families, and I know we've talked about that on a few occasions. So I mean, I thought the report was brilliant. I'm sure that must be in there somewhere because I've made a note of it. But I think obviously that's is just one to watch because of the longer term implications of that.
Absolutely. And we are taking opportunities where we can to start feeding up the line, areas where we figure we need to be looking at sort of longer term as to what solutions we can put in place to facilitate, because we're going to be working digitally, for example, particularly, and so that we don't disadvantage people. Karen?
Yeah, it was just to provide some reassurance to the governing body in relation to the report that's been provided from a PPI perspective. Michelle and Julie Bailey, who oversees some of the work around Health Watch, they do feed back into the retrospective teams within the CCG in advance of this report being shared, so that we can pick up any themes, that we can address any concerns that are particularly being raised, and they're addressed by the individual teams as well, once they've been highlighted by Health Watch. So I just thought it was helpful to reassure the governing body it's not a report that's just presented to the governing body. It is something that's followed through in terms of action.
Thank you, Karen. Thanks. Okay, so we'll move on, and it's the finance report next. Over to you, Mark.
Okay, thank you. So this is the finance report up to the end of November, so month 8 in the financial year. And at this stage, the headline message is that the CCG is awaiting further allocations. And because of that, the current position shown is around about a 3.9 million deficit. However, the allocations that are due are low risk in terms of receipt, and therefore the true underlying position for the CCG is more like a break-even position. So the headline message is 3.9 deficit, but in reality, that funding is expected to be received. In terms of the position with our providers, the CCG has received system-wide allocations, and earlier in the year we considered how they might be deployed across the system, and we retained some funding within the CCG at that point. We've heard earlier in the meeting about the pressures within the system, particularly in the acute sector. So we've reviewed the funding split and we're able to deploy further elements of that funding out to South Tees in the current month in terms of month 8. As we move forward over month 9 and month 10, we're all clear that the pressures are continuing and there'll likely to be further deployment of those funds from the CCG out to providers in the acute sector. The positive message is that the CCG and the other 3 key FTs within our ICP are all heading towards a balanced or close to balanced position, and the deployment of these funds helps to demonstrate how we're working across all of our partners in terms of making best use of this resource. It's not sat in any one place, it's being deployed as and when it needs to be. And I think that's a positive message for us to take away. So there are pressures in there. We are responding to that, and we're making sure the money hits the front line where it needs to be. But happy to take any questions, Paul.
Thanks. Anybody, any questions or observations? While people are thinking, it's useful to hear the finances being deployed to the acute sector, but I thought it'd be worth checking that there are equally where the finances are being required as a result of COVID pressures elsewhere in the system that we're commissioning, that presumably we're deploying appropriate levels of support financially there.
Yeah, absolutely. So within the document, it specifies the funding that's being fed out to mental health, for example, for TZESC and Wear Valley and other partners. But in addition, there's significant sums to support the hospital discharge programme, so supporting continuing healthcare. And indeed, the national funding is helping to support some of the vaccination work that we've spoken about, and also primary care generally. So there are funding flows to each of our systems, supporting the pressure where it's emerging, be that primary care, secondary care, mental health, or other community services.
That for the record. Thank you very much. Okay, thank you very much. Any other queries, questions? No, we'll move on. So governance, assurance and risk report next, I think. Is that right? Let me just double check.
Is it Jean's quality report?
Oh, sorry, yeah, quality report. Apologies. Yeah.
Sorry, Pos, I thought you were just being a bit flexible again, so I wasn't going to speak.
Well, that was as a result of having been flexible. I'd lost track of where I was in my agenda. Yeah, over to you, Jean.
Well, I am very mindful of the time, Pos, so this will be whistle stop. A couple of key things. So on the assumption that everybody's read and inwardly digested the paper, I will of course be happy to take any questions. But for South Tees, just to bring your attention to the fact I am referencing there a Never event from October of last year. We're talking there about 11 since the 1st of January 2019. Elsewhere, I have referenced a much larger time frame in terms of our concerns. Talking there for South Tees about things that colleagues are well cited on, and also the continuing concerns about mortality metrics. Just to stress for anyone who's new and unfamiliar with this, these are metrics. These are indicative of looking at other areas, and they are always taken relative to elsewhere. For North Tees, just wanted to bring your attention to some really good work that will be working its way through the Quality Committee in terms of the ERCP related incidents. Since this report was written, we've had a meeting with the medical director, excuse me, director for the Trust, who's given us a very comprehensive update on the quality work that's arisen as a result of some CCG concerns that we shared, and we gave some input. So that's been really helpful, and we hope to share that at a future quality committee for the benefit of all colleagues across the patch. So that is showing the benefits of that quality committee. At the risk of being repetitive, I do mention this each time, we continue to work with Tube and be concerned about their backlog of serious incidents. And I've talked to you there about the meetings that this does get raised in. We've previously had questions about where are we in relation to this and what assurance do we have, and I thought it was helpful to reference just all the places where this does actually get discussed. Talked a little bit there about Stockton Affective Disorders team and the reference in the improvement work that's going on there. And then also Rosebery Park, this is, sorry, but I don't know if you can hear that in the background. Yes. So it's either me coughing or the cat meowing. I'm very sorry.
I will forgive you.
Yeah. So moving on, Northeast Ambulance, talked quite a lot bit there, but I think it's relevant and helpful to talk about how COVID is impacting on ambulance services as well. We do discuss a tremendous amount of the excellent work being done in trusts. And when we think of trusts, we often tend to think of our acute trusts. Of course, our NIAS colleagues as well are dealing with this. And Craig has previously talked in relation to the impact on performance and such things. Reference in there a never event for CDDFT as well. And then I have included in this report, the Ockenden report. Now, Alex is not with us at the minute, but she is leading. This is the report that came out from the maternity services at Shrewsbury and Telford. Very illuminating report with a lot of very urgent actions, and that relates to provision of maternity services, which Alex is leading on, but just to reference that in this report. And also to bring your attention to under independent providers of care, there's some work there in terms of the Priory. This is on the basis of their CQC inspection last, excuse me, last September, and the improvement work that we're supporting them with. You will see, for colleagues who maybe is not familiar with looking at the CQC websites, I've put the link there which will take you automatically to the publicly available report, should colleagues wish to look at that in detail. And similarly, I've also referenced some concerns that have been ongoing for in excess of a year in relation to our hospice colleagues at the Butterwick. Again, happy to take any questions as we're going along. And that's it, really, a whistle-stop tour. I do know colleagues have had the opportunity to read the paper, so happy to take any questions. Sorry.
Anybody with any questions or queries or comments? Yeah, David?
Just with regards to the Butterwick, it says plans to open 5 days a week, Monday to Friday. I just was wondering the practicality of that with people with advanced disease and near end of life, how we feel that's going to work in practice.
It's palliative care patients, so it's for the respite palliative care, Monday to Friday.
So respite, thank you.
Yeah.
Just quickly to touch on the Ockenden report, presumably that's any relevant useful information from that is going to be fed into our clinical strategy groups for them to reflect on if need be. They'll be aware of it anyway, but just to get assurance that that'll happen.
Absolutely, Pos. For any colleagues who've read the Ockenden report, and can I urge you to read it? That's why I've put the link there. There are detailed expectations around that, both in terms of submissions of assurance. Normally when these national reports come out, they say you've got, you know, X amount of time to respond and submit. It came out and within very short time frames. So within a week or so, there was expectations around submissions. There was further submissions requested in January. They've had to be moved out by a month because of the increased wave of COVID. But it is very stringent expectations around that. There are additional recommendations arising from the work at Shrewsbury and Telford, but also the Ockenden report does represent a summary of that which should have been, it's a catch-all would be the wrong term, but it's a roundup of a lot of other maternity services related improvements from other independent investigations. So it's a watershed. There will be no presumably about it. It will be done, and also it is very prescriptive around the governance for this, both in terms of the local maternity systems, the maternity services networks, the commissioning of, the delivery of. It runs the whole gamut. So I would highly recommend colleagues to read, because they will be seeing things coming through. Alex is our commissioner, our director of commissioning for women and children, is leading on this, because it is much more than just what happened at one particular place and the quality and the governance around about that. This represents a fundamental review and a seismic shift in both expectations and the associated assurance. Sorry.
Thank you, Jean. And in the absence of any other questions, one last assurance question in relation to our quality processes while we're having to deal with a particularly high COVID surge and pressure in the system, that between yourself, Andy, and the quality committee, that you're adopting an appropriate juggling act in relation to not burdening our providers inappropriately with information seeking, but you are keeping your fingers on the pulse of the quality delivery of services in these difficult times.
Well, it doesn't matter what I say, Pos, it's for others to judge, but I would say that we're working very hard in a partnership way to smooth out things as much as possible. But I think that Amanda Pritchard's letter of yesterday is a game changer, and we will reflect on what that means for us as a CCG, because if it means all clinical people on the front line, then that's what it means. What I would actually like to say is the Chief Nursing Officer. So earlier on last year, you will have seen in the governing body papers, and indeed I've referenced it under the safeguarding this time around as well, that previously we flexed the safeguarding team to cover, to allow release of individuals to support the IPC work. Myself, I went into one of our providers to support as well. In the summer months, the Chief Nursing Officer came out with a letter and said that safeguarding personnel must not be flexed. So that's the majority of our team. So again, with the benefit of Amanda Pritchard's letter yesterday, we'll be looking as to what we do and how we do it. And we've already talked about how trusts are stepping down their reporting. They still have their statutory responsibilities to understand that they're safe, but perhaps just not servicing quite as many assurance committees as they would do previously.
Thanks. Andy, any last words before we move on?
Yeah, I think it's safe to say we're being cautious and we're being supportive without taking our foot off the gas. We have our duties as a CCG to maintain the quality outcomes, and we're doing that as best we can, but recognising what Jean said, we have to do that in the context of everything. So, yeah.
Lovely. Thank you very much. Okay. Thank you, Jean. Now moving on to Jackie and the Governance Assurance and Risk Report. Over to you.
Thanks, Paz. just quickly moving through the report as usual, provides a summary of some of the areas of activity since the last report in November to the governing body. Firstly, we've just acknowledged there the governance processes that were in place to appoint and welcome Alistair and Joanna onto the governing body, how we work closely with the local medical committee to run the election process. So congratulations and welcome to you both. The risk update this time round is brief. We'd agreed as the governing body that we wouldn't bring the full risk register and assurance framework to every meeting, but in the intervening months, I would highlight if there were any new risks or any significant changes to the risk profile of the risk register. You can see that I've identified 3 fairly low level residual risks that have been added to the risk register. 2 are in line with data security and protection toolkit requirements in terms of having a cyber and an overall information governance risk on the registers, and it's in line with good practice. And I think we do have an awful lot of controls in place to mitigate against these risks. We had a detailed update in terms of cyber at the Audit and Assurance Committee in December, where Alison Emsley, the cyber security specialist, presented how we comply and how Next comply with the Cyber Essentials toolkit. And there was also the opportunity for some voluntary training at the staff event yesterday. So those are 2 new risks relating to cyber and information governance. And then there is the reoccurrence of the impact of EU exit. Members who were around at the time will recall that this was a risk on the risk register in the early days of the EU exit process. We've got again, there are a lot of mitigations, a lot of actions in place to hopefully avoid this actually turning into a significant issue. And the report does include a little summary that was provided to all CCGs about some of the national mitigations in place relating to EU exit. So you can see that's a very low level risk. None of those 3 risks are on the assurance framework, but they are on the risk register. I'm currently working with directors to update the risks in full prior to the February governing body development session. At the moment, in terms of the draft agenda, we'll be looking forward to the following year and what that might mean to us in terms of our risk profile, but also in readiness for the end of year annual report on how our risks look in comparison to the rest of the priorities of the organisation. Section 4 highlights some of the processes that we've got in place in terms of declarations of interest. I have to be honest, we were, because of the pressures of COVID, we recognised that the mandatory training element of the requirements of the statutory guidance were causing some difficulties, particularly within practices this year, and completely understandably. I've been really impressed over the last couple of weeks how helpful the practice staff have been in terms of trying to do that alongside everything else. We've tried to make it as simple as possible, but as of this morning, we now have 94% of all staff and clinical practice staff, in terms of those that are classified as employees within the CCG, are compliant with the training, and that equates to 87 out of 93 staff. So that's come on quite a long way. And I think that great big thanks to all staff for doing it, and particularly those working within in practice to do that. That being said, it's still slightly short of the end of January target, but what we're trying to do is just ensure we have some mitigations in place. We know any declarations of interest that those staff might have had in place, so that we can ensure that we're as transparent as possible with the public in terms of any declarations or any risks that might cause to the CCG or to those individuals. And I'm quite confident looking at those that we don't have anything significant there. We did also provide...
Jackie, before you go on, I think Alistair's raised a hand.
Sorry, I can't see the hands.
Yeah, no, absolutely. So Alistair, yep, you got a comment there.
Hi, thanks, Jackie. Thanks for that. Just a small point of detail, really. For my benefit as a newbie, but also because this is going to reach the public, you've got some risk scores which up of a couple of different numbers. Could you just sort of give me a brief outline what they mean and how you arrive at these numbers, please?
Yes, certainly. Normally you would see the full risk register in a much more detailed report, so apologies for that, Alistair, and I'll make sure that you get some induction and briefing on that. The C is consequence, and the L is likelihood. So what we start off with when we're considering risks is the consequence and likelihood of a risk occurring. It's using a standard 5x5 matrix that's adopted across CCG and national standards, really. The initial risk looks at what we feel that risk would be should we not have any controls in place whatsoever. So we've recognised the risk. That's very nice, thank you very much, and not doing anything further with that. We then look at the controls that we have in place and how we're assuring ourselves as well that those controls are working. So it's not just saying, well, we do this, it's how are we measuring or how are we reporting either internally or externally, any external reports that might justify that as well. Sorry, my keeps popping off the screen. We'll back that up, whether we've got internal audits, national reports, etc. So we then rebalance the scoring of that risk, and what we tend to do is look at all of the risks on a quarterly basis. Each risk has a director lead for it, and each risk is allocated to one of the CCG's committees. So the quality risks are looked at by the quality committee in a bit more detail, primary care related risks into the primary care committee, things like information governance, cyber goes into the audit and assurance committee. The executive committee has overall operational management and overall oversight of all of the risks on there as well, and to make sure that we're doing what we need to do. So normally, sorry.
That's perfectly enough for me. Thank you very much. I just wanted to know what the C and L meant, but thanks a lot, Jackie. That's wonderful.
No problem, and I'll send you through a little bit more information separately. So finally, just going back to the conflicts of interest, just to say that I think I was just saying that the audit committee received a detailed update on the processes that we had in place at the December committee, and we are expecting our annual audit from Audit 1 to start sometime in early February. We've been notified of that audit, so we're just waiting for that to start. But I think we're in a relatively good position. So happy to take any questions.
Okay, anybody else with any other questions? Okay, thank you very much. Moving on to Karen then, and 1 year in primary care networks.
Thank you, Paz. I'm assuming that members have read the report that we've provided. I think it's worth starting with. Often we look at the negatives, and certainly at the minute, whilst everybody's working at such a fast pace, we thought it was really important to celebrate some of the successes, and particularly the successes of our primary care networks. So in terms of the document that's provided, what we've tried to do is we've tried to highlight in a number of areas the work that's been undertaken in the last year. Primary care networks, believe it or not, celebrated their first birthday in July last year, and what a year it was. Obviously, it was unprecedented in terms of the challenges within the NHS in relation to delivery of just general practice, let alone transformation and bringing together groups of practice to work together. I think in terms of where we are from a primary care network perspective, I don't think you can underestimate the work that's been undertaken in the last year across practices and across our networks. We have 14 networks within our area, and we have 16 clinical directors. Through the year, we've seen changes. with our clinical directors, with some who started the process and then ultimately have decided to retire. That wasn't because of primary care networks. We've saw babies being born into our primary care network grouping, and you know, 5-day-old babies being brought to some clinical director meetings, which was great. So we're starting early in terms of the recruitment within primary care and within the networks themselves. But I think some of the report actually highlights some of the key successes. You'll see some comments that we've got from some of our clinical directors and some of the managerial leads. It highlights the services that have been delivered by the networks. It highlights in relation to workforce and the new requirements in terms of recruiting additional workforce into primary care. It also highlights the support that we're providing our networks from a clinical commissioning group perspective and the work that we're undertaking and hoping to undertake in the future, obviously subject to the pandemic response. The networks didn't stand still during the pandemic. We still continue to meet with our clinical directors on a regular basis to look at the work that they're undertaking in relation to the pandemic, but also in relation to how we move forward in terms of certainly the workforce and being able to attract workforce and retain staff during what are unprecedented times in the NHS. I'm extremely proud of our primary care networks and where they are now. I think in terms of the maturity, we have a different level of maturity across our networks. But I think in terms of where they were when the pandemic hit last year, they were 9 months old. And they were just getting to grips with how they could work together to deliver the services that were prescribed by NHS England, let alone deal with pulling together a pandemic response as a group of practices and the COVID challenge that we've had. So you'll see within the report, obviously, we've set out some of the detail in terms of who the networks are, which practices belong to each network. We set out the key deliverables that they needed to provide over 2019 at the inception and then through 2021. And we've also described the growth in terms of the recruitment across the area in relation to whole-time equivalents with the roles that were described last year. Obviously, recruitment has paused in some areas because of the pandemic and the approach for this year, but we're certainly working with the practices and the PCNs as we move forward to make sure they're able to pick that up as we move forward. One of the areas that was highlighted was particularly around leadership. And certainly these are the clinical director roles within primary care networks. They're part-time roles. The roles that clinical directors are delivering alongside of their day job. And it was really important that there was support in place to make sure that there was some ongoing leadership development. We bring together clinical directors across our networks to share and have peer discussions and also to support one another. And that's certainly been advantageous during the pandemic in terms of ways of working across the networks and the groups of practices. We've outlined the support that we've provided as a CCG to help support our PCNs, and that's not just support provided by the primary care team, that's absolutely support across the whole of the CCG, from digital estates, from finance, and also from our clinical teams, medicines optimization teams, and our commissioning development teams across the whole of the CCG. So this hasn't been done in isolation in terms of some of the key pieces of work that we've taken forward. The networks have developed really good relationships with provider trusts and with our local authorities and also with each other. So we've outlined in the document as well the next steps and what we are hoping to deliver through this coming year. And obviously we'll continue to work with the networks as long as the pandemic response allows us to make sure that they're prepared. We've had some really lovely remarks from the clinical directors that are included within the document. They were engaged in the production of this, although again it was a difficult time because we were trying to produce this alongside of the pandemic response, but thought it was really important that we do recognise the success. We've had excellent engagement from our LMCs across both Cleveland and County Durham in terms of not only supporting the practices but also supporting the wider system through the unprecedented times that we've seen over the last year. So we just hope to see that our networks continue to grow in their success And obviously, as we move towards a more systems-based approach as we move forward, they're in an absolutely great position to enable them to do that. That's all.
Thank you, Karen. It's a great document, and I really like your closing remarks bit as well. You know, you've done an awful lot of work with the primary care networks, and you've helped to deliver and been the main movers, and your folks on your side of your directorate have really sort of help to facilitate a really good outcome for our primary care networks, and they're going to be in a nice position for the major role that I figure they're going to be playing in the new forthcoming likely ICS structures. And it's going to come down to a locality liaison with all of their local stakeholders. So it'll be interesting to see how things pan out in the future. But you've put them on a really great footing, so thank you very much. Anybody else, queries or comments? Yeah, Stan.
Well, there we go. Sorry, guys. I think it's really important that you highlighted there, Karen, about the support for the clinical directors of the PCNs. It is a part-time role, and a lot of them have been working, a lot of hours. And I've worked really closely with Amanda Riley down in Darlington, and the team, and Dr. Candy Condon, the different networks, and the amount of work that goes in is incredible. It's phenomenal. And we're seeing high levels of resignations of clinical directors across the country. And I think it's really important that we do everything we can to support these people and stay in those roles and give them all the support they need, sort of time-wise, in order to keep that going. Because if they do sort of pull back from that, we need to find other people to take those roles on with the same problems. So I think the peer network support is great, but also just time, I guess. I think because the workload is going one way and time goes the other way.
Caroline?
Yeah, obviously we discussed this at the primary care committee when it came to the primary care committee, but it is a cracking piece of work, and I think there's some really brilliant examples in section 7 where it gets stuck into the place-based stuff that's going on as well, and it really brings the report to life. So I just wanted to say formally, well done. It's a great piece of work.
So, thank you very much. Look forward to primary care networks development in the future, and see how things develop in the new structure as it slowly emerges. Excellent. Now, going back to my agenda, primary care networks. So, reports from committee chairs. Anything that anybody wants to flag or highlight from the committee reports at all, folks? No. And moving on, integrated care, next steps in building integrated care systems across the system. We've slightly touched on that in the discussion of Karen's paper. Dave.
Yeah, thanks. It was a very helpful segue, Pos. Probably not going to say much on this. The paper that you've got is the official document that came out for the consultation. We've had a process within the CCG where we've had discussions as a governing body. We've had discussions with the clinical directors of the primary care networks, with the council practices, and also with the staff and directors, as a result of which we put in our response to the consultation on the closing date of the 8th of January. We haven't heard anything back just yet, and I think that's probably one, because they're trying to make sense of all the comments they've had. Two, I think to be fair as well, because of people dealing with COVID. But in the meantime, we're starting to have conversations and thinking about, well, if this goes forward in the way that the consultation suggests, what does it look like from a North Cumbria and North East ICS point of view? So we'll be involving governing body members and the team as part of that as it moves forward. But I guess early days, it was more just to formally lodge this in terms of, we've got the document, we responded to it, and then we'll have conversations to see where it goes to next. So happy to try and take any questions, Pos, but it was as brief as that, to be fair.
Well, my one comment just now is particularly that sort of section 1.13 about place and the integration of building block for health and care integration. And this is probably where we'll be sort of further developing the sort of close meshing with local authority working and public health knowledge of the place agenda. So Craig and Esther, has there been much sort of discussion as to the place of public health and local authority items in relation to the ICS structure that you're aware of that would be useful to feed in here? Esther first and then Craig.
Yeah, I think all I'll add is that we've been heavily involved with the planning throughout with the ICS arrangements. So right from the beginning until the new phase as to the states in which we are now. So we're working very closely with the ICS and will be part of whatever arrangements that are put in place. I mean, it's more of a consultation arrangement, but we've been very heavily involved in the process.
And Craig, any observations?
Yeah, no, just a very similar view there to Esther, but it is, and I know certainly from our perspective in Hartlepool, that kind of approach and a place-based approach is key to the work we're going to develop moving forward. So, yeah, we'll be working very closely alongside you with that.
Okay. Anybody else? Any other comments? Yeah, Dave?
And just to probably emphasise that, our 5 local authorities put in a combined response from the 5 managing directors or chief execs, the leaders and the mayors, and they've very much played up the importance, as we'd want them to, and as we would, of place and how that works out. I think once we get the formal response back from NHS England, we need to do quite a bit of work just to make sure, to be fair, we continue the direction of travel that we've got, which is the bit I'm picking up. We're heading in the right direction anyway. We just need to take it a little bit further and make sure we get that local reach into local authorities, but also into communities within local authorities as well. So we need to see what comes back.
Thanks. Okay, so move on to, for the last little bit, items in the left to do. CCG minutes received from the Primary Care Committee, Executive Committee and Quality Committee. Anything to flag from those? No, nobody. Right, okay. Other minutes received from the Northern CCG Joint Committee, Hartlepool Health and Wellbeing, Joint South Tees Health and Wellbeing Board, and the Stockton-on-Tees Health and Wellbeing Board. So those have been received. We didn't have any other business notified. We did have a question from a member of the public. We're hoping the member of the public would be here to actually hear and witness the response. Unfortunately, they're not. So the question was, hi, I'm a 68-year foster carer for 17 years that had a heart bypass in 2015 and am diagnosed with heart failure and suffered 3 episodes of pneumonia in that time. I'd like to ask the question as to what stage I'd be eligible for the COVID-19 vaccine. The authority I'm engaged with say they don't know if we meet the criteria for the vaccine. I can't give a definitive answer, although I look after 2 vulnerable young people that attend college, see their family contacts and live with me 24/7. And this kind of reinforces the sort of level of interest and that Michelle was also highlighting in her patient and public involvement. So Janet's answer, I'm not going to read in detail, but Janet's answer has been forwarded on to the member of the public. Effectively, and she's done a very nice, long, detailed response, which will be forwarded on. Now, it does highlight the fact that foster carers are eligible on the list for vaccination as frontline workers. However, those at the very highest priority are staff working with significantly older adults, because we've heard that older adults are particularly at risk of the significant illnesses and death from COVID. So those are at highest priority, and they're prioritized before those working with children. But he'd be likely to be called shortly by the local authority to make an appointment for a hospital hub for vaccination by virtue of the fact that he is counted as a frontline worker. So that was our public members' question. I hope they've found the response from Janet interesting and useful and illuminating and reassuring. And on that note, that's it from the members of the public. Lastly, last but not least, any impact on our risk register from any of the matters under discussion, Jackie? And once again, we kind of sort of touched on the risk register items that you raised earlier. But apart from that, I can't think of anything that really significantly changes our risk register either. There's no no's around the board as well. So we'll move on. And thank you very much for attending this meeting. It's been interesting doing it again in Zoom. It's working pretty well. Apart from we've noted, we had a staff session earlier in the week. And everybody's big bugbear seems to be you're on mute when you start talking and you don't get it quite right. Everybody does it, absolutely everybody. Even us old hands at it. So date and time of the next meeting is Wednesday the 24th, venue and time to be confirmed. So thank you very much for your attendance. And